So Duncan, why don't you start?
Erin Schmid is the wound care and ostomy nurse for VCH, GF Strong, and Blusson Center. And she has been in that position for quite some time. I don't know exactly how many years, but I have dealt with her in a number of situations and have found her to be extremely knowledgeable. She knows her stuff. She can be fun sometimes, and she will hit you with the truth sometimes. So I asked her to do this presentation, and I know she's not really comfortable with doing presentations that much. So hopefully we can have a major discussion group. But I sent her all the questions that we generated 2 weeks ago, and I want to thank her for doing this. So with that,
Hi, yes, I've been a nurse for I think about 20 years now. Just a bit of my background. I did start on the burn and plastic unit at VGH, and then we amalgamated with trauma special care. So I did some more training and specialized in trauma. And so it was basically a lot of wound care with burns, plastics, and trauma. Then I did a bit of ICU training. I didn't really enjoy that. So I actually moved into the wound care team about 6 years ago. And I've been with the SCI community since then because I took on the Blusson role and GF Strong. So I was kind of in this and working with Dr. Pap. So I kind of took this role of working in a clinic, a bit of rehab, and acute care with the SCI population. So it was a bit of a learning curve, but it's been kind of an interesting learning curve. And yeah, so hopefully I can share some stuff with you today. And if you have questions for me, I'll answer them. I'm on vacation, so there's no hurry for me today. And if I don't know, I can always try and figure it out and give the answer to Duncan, and he can give it to you down the road. So, okay, next slide. All right. So the question was, I guess, aging issues. This was a big question for me. So I kind of went with, why do we age? What causes us and how does it affect us? So obviously time. It's kind of choiceless. It's predictable, and we know the ending is unknown when time ends for us. But time is obviously our nemesis, and it's going to affect us. So what can increase and kind of cause our aging to either go in a nice way or not in a nice way is obviously, our nutrition is actually quite important to us. It helps our bodies, feeds our bodies. So good versus poor nutrition. Unfortunately, alcohol use has a big effect. We're learning more and more that, even one drink is starting to become a factor in how we age. Obviously, drugs of the illicit sort, we all know are not good for us and they affect our aging. Smoking cigarettes affects our aging, increases it. Lowering of exercise, sort of lack of sunshine, and honestly, lack of being happy. Can all sort of affect how we age. And what this looks like for our bodies is it can affect our bowel routines. When we have poor nutrition, we drink, we don't exercise, our bowel routine gets off, which then affects how we feel all the time, and affects our overall health. Our skin naturally ages as we get older. Having too much sun can affect it more. Smoking cigarettes affects our skin. It actually thins it out even faster. Our muscles deteriorate naturally. And then, of course, all of your muscles below your level of injury are already affected from that. So you kind of have a double whammy there of thinning muscles. Obviously, obesity is quite a problem as we age. We sit in our chairs, and the longer that you sit in there with sort of a bigger stomach, the more inertia of that weight can sit on your chair, increasing risk of wounds, obviously. And then that all sort of wraps up in poor heart health. Okay, next slide, Duncan. So if we're looking at, I think this is a lot about bowels and as we age. So again, talking about that sort of weakening muscles, it's amazing how having stronger, healthy muscles keeps our bowels in good check. A diet can really affect. If as we age, we think we can eat what we ate back when we were 16, we obviously can't. do have to learn that our diets have to change as we get older. You know, we got to make sure we're drinking that water. Strangely, as we age in our brains, like when you start hitting 60 and above, that cue in our brain that gets that signal that you're thirsty actually slowly gets turned off. It's just a natural biological thing in our brain. And so it's almost as we age, we have to realize I haven't drank enough water because my body isn't sending that signal anymore or as strongly as it used to. And that's sort of where you hear, and there's a big heat strokes out that a lot of older people end up passing away from dehydration. So it's one thing that keeps our bowels as well is water, water, water. And that's like fibrous foods as well. Your fruits and your vegetables, you know, we hate them, but they're good for us in the end. Pain medications, you know, we have some issues as we get older. We get some arthritis. We just get that sort of slowing and aching of our bones. And the more pain medication we take, obviously slows our bowels down. We have all these receptors in our bowels, and we have drugs that attach to those receptors, and that can slow our bowels. So sometimes we have to kick off, and some of our laxatives will actually reattach. But those are things you have to chat with a doctor about, like which pain medications are good with which bowel medications as well, so that you're always having a good bowel movement. So we look at pain medications. Obviously, you know, we have the world of antibiotics, and we know, you know, not every drug kills every bug. Antibiotics are great when you have an infection, but obviously the more we take them, the more, even if it's for a UTI or something else, the effect on the bowels of an antibiotic, we always have good and bad bacteria in our bowels, and they're meant to stay in harmony between good and bad. We need both. You know, you take an antibiotic for a toe infection, it does kill off a lot of the good bacteria in your bowels, and so then your bad bacteria grows. Then people get irregular bowel movements, they feel tired, they don't really know what's wrong. The foods that they used to eat kind of just give them diarrhea now. And it's, again, it's putting those bowels back into good and bad bacteria. How we do that, it's a tough road. Obviously, you know, not taking antibiotics, but sometimes you can't help it. Maybe looking at foods that add probiotics back, or talking with your GP or your physiatrist to say, hey, you know, is it worth me taking a probiotic because I've taken like 4 rounds of antibiotics this year because I'm getting UTIs. And putting that back in balance constantly will make a difference in your bowels. It also strangely makes a difference in your skin. You know, when your bowels are balanced, it's like everything else in your body balances. So it's strangely a very core root of our health that we don't think about and no one really talks about. And it helps me with wound care to know, you know, what is your current health and actually what is your bowel health? Because actually can help if you're good and bad balanced in your bowels, then you have a better chance of having a good and bad balance in your wound, and that can help you heal your wound better. So it's, you kind of learn it's all connected. Okay, bowel medications. I kind of talked with one of the physiatrists about this, and she was saying that, you know, when people start a routine, they sometimes start high in their medication. Let's say the range is between 5 and 30 milligrams. You know, to never start at 30, because then you got nowhere to go. And to start a new medication lower, she suggests, so that you have a place to go, so that, you know, you go up to 10, you find 10 gives you what you need in getting a good bowel and getting a good bowel movement, and that's where you stop. So at least as you age, you have room to move up in that medication, because that's just natural. Okay. All right, go to the next slide. Were there any long-term effects of bowel care and treatments? About digital stimulation. So I did have to get some help with this. They say it should stay stable when you do digital stim, that it shouldn't cause any injury too much. But I mean, it is sort of not normal to, you know, put your finger in your anus and stimulate it. that before you were injured, you had the natural flow. But if you're doing it right and you're getting a good result, your body does have the ability to stay elastic in that area, and not have too sustained injuries in that. Obviously, you have to, couple it with suppository use, enemas, and laxatives. And again, just sort of going back to, not overusing a medication right up the front and right off the bat, I mean, and keeping it sort of on the low, working your way up in that medication's limits till you get a good result so that you have room to go up and down. Obviously, I'm not here, I don't really know the drugs per se. I've been out of working at the bedside to know the drugs that well. But that is whoever you work with your bowel medications, whether it's your physiatrist or your GP. I'm not suggesting you change anything, but it's always a good look at what your medications are and if they're working or not, and have a good discussion again with your GP or physiatrist who kind of works with you with your bowel medications, because they know what other drugs you're on, and then they know how those drugs work with your bowel drugs. So everything kind of affects each other. It's sort of, nothing works in silo in our bodies. It all is interconnected, no matter what. I guess there was a question about hemorrhoids and why they're so prevalent in the SCI population. Well, I mean, the neurogenic bladder disorder comes obviously with a lot of the spinal cord injury, which, means that everything below your injury works a little slower. It doesn't sort of have that natural flow that it did before. And so you're having to kind of, transit time of stool as it moves through the intestine can slow down for some people. When stool moves more slowly through the intestines, it can then take more water out than we request it to, and it gets drier. Like as our stool is quite liquid in the small intestine, and the job of the large intestine is to remove water, some of it out, but obviously to leave enough for proper passage. Our large intestine also has mucus in it that allows stool to move through it, but we still need some water to move that through. So the longer it stays in there, the more the large intestine might take out. Thus, a lot of our laxatives add water so that it moves a little bit more smoothly. And so if it's too firm, you're kind of bearing down and working a little harder to get it out. And that just puts a lot of pressure on sort of that anal exit site and increases venous pressure. Those veins get a little too annoyed and irritated, and they make little polyps. So it's kind of one of the reasons why. Some of it is coupled then with that digital stimulation and a bit of a salt down there. So it's kind of all, it's just sort of the way, the natural thing. Obviously, if they're irritating and bleeding, there are things doctors can do to sort of clip them off or do some cautery. So don't let them get too big and too bleedy, because that can cause a lot of problems. Obviously, every time you have a bowel movement and it bleeds, it's not good for you either. It's a risk of infection in the blood if you get stool in your blood flow in your blood. So we, get it treated. There are some creams, there are some surgeries, but it's one of those things, you just might, it's just sort of prevalent in a spinal cord injured person. But adding water, getting your bacteria rebalanced, eating better foods, exercising, all those things again can work in tandem to kind of hopefully decrease maybe how bad your hemorrhoids might be.
Can I focus on the second one that says, do they get worse with age?
Of course they do. Everything gets worse with age. Yeah, I know.
I was
Nothing really
waiting for
gets
one of
better.
those answers.
Yeah.
I was waiting for one of those answers.
Just our wisdom gets better. But yeah, unfortunately, I mean, everything gets thinner and looser, and it's tough. It's almost like the older we get, the harder we have to work at keeping ourselves better. And it becomes more of our job. Yeah, there's no good answer except for just trying to.
Next slide.
Yeah. All right. So colostomies. Originally colostomies, were just given to those with bowel cancer. from what I've seen in my career. And those that had, really huge coccyx, perianal buttock wounds that people were soiling into it. So we wanted to decrease infection. Now working sort of more with your population over the last couple of years, and some of the physiatrists at GF Strong have really kind of looked at quality of life of a colostomy, and sort of seeing and hearing stories of, I was out and about, I had an accident in my wheelchair, and I have to go into some mall and get two people to lift me up just to clean me up and get back on my way. And others stories of it. I'm sitting on my commode for an hour and a half trying to do a digital stim. I have to do this every morning, and I'm like, an hour and a half. I mean, my God, you could go through 3 magazines. That's a lot, and that's a lot of your time. That's not fun. There's other things to do in life besides sit on a commode for an hour and a half. And the increased risk of wounds in my world.
Routine every day is a lot.
It is a lot.
Just talking about sitting on the toilet for an hour and a half is a lot. Try 4 or 5.
Yeah.
Yeah, but it's just not, it's, if you think if there's something, it is a surgery. It's a surgery. Every single surgery has risks. What makes it sort of in the better of the risk is that these doctors do these surgeries all the time. And so that gives you some comfort. There is obviously, you can't be severely obese. There needs to be room between your inner belly and to the outer belly through all that. If you're, reaching 400 or 500 pounds, the layer of fat, it just can't be reached. And so not everyone is a candidate. But we've been doing a lot more quality of life colostomies. They're typically on the left side of your abdomen. That's sort of where the larger bowel is closer to the same as the exit site of our anus, that last loop that goes down. And so then the stool is almost the same consistency as when it exits out of your anus. Because it's that last leg, all the water's been taken out. So whatever your bowel routine was prior, typically after surgery and your bowels have kind of bounced back, it's typically the same than that. I know some people are quite scared of ostomies and having that sort of, well, I've got a colostomy. Can they smell? The products today, like I've never really smelt one unless there's leakage behind the flange, and that just means you need to go change it. But that's the same as before. We toot it out in public. We've had accidents out in public, and it's the same thing, except for it is a bit more contained. You can go into a washroom, change the bag, put on a new bag, wrap up that bag, and off you go, in a washroom situation as well. It means you're doing bowel care on the front of your stomach instead of behind you, and actually where you can see it. We've even had quads get them. They do have, some 24-hour caregivers, so they can manage the bag and the care for them. But they're still able to do more things and be out longer in public because they can go into a washroom, have someone change their bag or empty it, and off they go again. What else? Is there any questions? I'm sure there'll be a lot of questions about this one.
This was a big topic of discussion.
Yeah.
So it'd be good to have some of that discussion with you here.
Yeah.
I know, and I've told everybody that I had it done, and it's been a blessing in disguise. It took me like 6 months to decide to do it, but once I figured out which appliance to use, I've had very few issues, and it's 10 minutes a day instead of 2 hours every 2 days. I can just get up in the morning and go. I don't have to sit on the toilet for 2 hours before I go. And, the only issues that I really have with it is you have belly farts, which can be kind of loud. So that's an issue. I was going to ask you if you can control gas. But other than that, I haven't had any problems. And I know Sean, I don't know if he's online because I can't see who's online, but I know he's the same opinion as I am. So it's if anybody else has questions, I would definitely ask them now.
Duncan, this is Sean Lynn here.
Yeah.
Are you do it yourself, Duncan?
Yeah. 10 minutes.
And I mean, with your hands, hand function,
Yep. And my hand function is not great, you know? I've
Okay.
got one hand that I can clench a little bit, this one, and my other hand's like a pancake. It doesn't do very much. But
Duncan,
it's not hard to do.
are you in a 2-piece or a 1-piece?
No, one piece.
Oh, quick, 1-piece, okay.
One piece, slap it on, take it off, cover it up and throw it out. It's
So
really,
everyone
really,
will, yeah, everyone will have a different way they, so the nice thing about, the colostomy appliance, if you can see the middle picture, that's, it might be a 1 or 2-piece, but you see there's nothing at the bottom to open. So we could say that that's a 2-piece. So you've got sort of the flange, the sticky part that sticks to the skin and the stomach that stays there. Then it's got a ring, kind of like Tupperware with a bag, they kind of snap together. So there's this one picture, you can see it's sort of a bag that doesn't empty, so you just kind of pop it off and throw it out when it's full and put on a new bag. So there's always that option that can be, and people can actually carry 1 pieces, 2 pieces, and depending where they're going, if they're on an airplane or just going out for the day or going on a weekend cruise, like they can go back and forth with what type of bag they want to use. Some people like the 1, some people like the 2-piece. So, when you work with a stoma nurse after, you try kind of all these different products and then you'll figure out what works best for you.
because
I
there's
see a hand up.
convex, there's flat, there's drainable, there's 1,000. I don't know actually how many there are, but it took me a while to figure out the right one.
Yeah. I see a hand up.
Yeah, that's Teresa.
Hi.
Go ahead.
It's the positioning of these things. Like I've had a couple of different fractures in my back. So I've had not only the neck, but also the lumbar. And my posture's severely affected by this. So my concern is if I like I'm reaching the point where it's becoming really difficult to do this and taking up a lot of time to do intermittent, right? So I'm looking at different options, and this has never really been there. But if it's that simple, maybe my hands are getting more or less operative, I'll say, because I think they are getting a little arthritic. And because my posture is like, where am I going to put that thing that it's going to sit? Because I tend to hunch over.
If you can see the bottom picture, sort of the abdomen with the red dots on it.
Right.
So there's the lower dot that would be for people who stand up and can, when we do patients in wheelchair, one of the dots has to be a bit higher. So a bit sort of mid abdomen, because we know that we need you to have access to your bag. And if it's really low down on the abdomen, it's going to get kind of squished. So we do recognize that it has to be a bit higher, which we've had to train the general surgeons to be okay with being higher, because you kind of have to consider people are sitting and they're changing and emptying their bags in a sitting position versus a standing up position. If it's something you're really considering, and we really do look at your stomachs when we mark you. So people like me mark for the surgeons because we are seeing you in different positions. But there's a lot of the ostomy nurses, especially around Vancouver, I can only really talk about. They will allow for a meeting and just to talk about it in person and look at your stomach ahead of time, just to even see if you'd be a good candidate, because again, not everyone is.
Okay.
Okay. Susan, you have your hand up? Go ahead.
Thank you.
Thanks a lot. It's Susan here. Some people with the 1-piece have a lot of issues with gas. And so how do you remove the gas from a 1-piece or without, if you're just say in a wheelchair in the middle of the mall,
Yeah.
can you release the gas there and easily, or do you have to, what's the deal? How would you,
Yeah.
is there a better appliance for
So-
somebody who's got a lot of gas?
So we'll approach it from a couple things. One, we try and see, is there a food that you notice produces more than normal? Then we'll say maybe avoid that food. With the one pieces, there are at the top, they're vents with a bit of charcoal behind them. They're not a perfect solution to allow the gas, but they help. That being said, if stool gets stuck up behind the charcoal, then it does stop. We wouldn't suggest in the middle of the mall to open up your bag, because it's the same as someone standing in the middle of the mall and totally farting. And we'd all be like, what are you doing? You can go into the washroom and open up the bottom of the bag, release the gas, roll it back up and head back out, just like you would.
That's only if you have a drainable.
It's only if if you have a two-piece, again, go somewhere private where you would normally have a toot, and you kind of open up from the ridge, you kind of open up the little flange, let them loose, and then you lock it back in together like you do with like a Ziploc or something, or oh, I've lost the word. Two things that
Ziploc.
Tupperware.
Yeah.
Tupperware.
Like Tupperware, you just kind of close it back up, click it up, and off you go again. So it's sort of the same. Like if I'm walking around a mall, I'm not just going to let one rip somewhere. I'm going to go somewhere and do it that way. So, you do feel the bag. A lot of people, you see them kind of touching and they were like, oh, I need to go somewhere and just kind of release some gas quickly. So there's it's two-piece. You kind of just open it up, let the release and lock it back in. A one-piece, you go somewhere, open up the bottom, let the gas out and roll it back up, and off you go.
Okay, yeah, this friend of
help?
mine got one. Yeah, she says that she looks pregnant most of the time because her bag is so full of air always.
Maybe we do sometimes, you can have a chat about what gives us more gas, like we kind of all know, like, oh, I've eaten two spoonful or two bucketfuls of ice cream, it's going to give you some gas. And for some people it's eating asparagus, and so it's something we kind of notice, and we cannot eat it as much. Otherwise you just kind of go around the corner and release it and off you go.
So she might actually have to use a drainable bag, even though she doesn't want to drain. She might not want to drain the stool, but she might want to use a drainable because you can just open it and let the gas out and close it back up.
Okay, that's great. Yeah, I wondered about that. I know they have those charcoal, whatever Erin was describing, but
They're not a perfect solution, but they do help. Yeah.
Do they all have?
I have to admit, it happens to me every once in a while. I have a little balloon hanging on my gut.
Okay.
And not that often though. And when it does, I just change it right away, because mine doesn't have any way to drain. Mine's just a closed system, so I just change it.
Okay. Okay. Very good. Okay. Good. Thank you.
Paul, you've got your hand up.
Yeah, thanks. So I've got a couple of questions, but first of all, I understand that gas is something that you're talking about now. Now, I wonder, with aging, I find that I have more gas doing the digital decompact. So I don't know that having a colostomy would lessen the amount of gas in my tummy or not. It would probably be the same, I would imagine.
Everything's the same.
Yeah.
Yeah.
Yeah. I mean, I always think, well, probably the gas can't get out because I'm sitting on my butt, and so then I get bloated, but that's not true, right?
It'll find its way out.
I thought so.
Yeah.
Okay. So the other question is then, the belly then wouldn't be any less big after getting a colostomy. It would probably look bigger because of the bag being there.
Actually, it just looks the same because the bags are flat unless they're full.
Okay.
Yeah.
Okay. All right. And the other question I had was, if you've got a colostomy and you're doing a lot of transfers, I tend to transfer a lot as a para. And so I would worry about things shifting loose or coming unstuck or what have you. I mean, that happens with catheters or condom catheters as well. So I worry, then I've just got one other piece to worry about here.
I don't think the bag hangs that low. It's usually quite a low profile on the abdomen.
But isn't it a problem then with putting pants down and up for catheterization when you're going to be hitting this bag all the time? It's right at the waistline.
The actual stoma, or mine, I don't know about Sean's, but mine is above the belt line.
Okay.
so you wouldn't hit it.
Hmm.
Mine
With
is
people
just,
in
I
the
would,
wheelchair, we're a little bit higher. Sorry, go on,
yeah,
John.
I would say mine's just a little bit below the belly button on the left-hand side. And it doesn't interfere with anything. Mine's just mine's a one-piece system. I do a lot of I'm C5-6 quad. I do a lot of transfers too, in and out of my van. I've got an off-road machine I use and all kinds of stuff like that. And I've never had one of these bags come off, ever. Never. They're just
So,
they just
so
stay
they're
right where they
they're
are.
just stuck on. They're only stuck on though with just
Yeah.
sort of glue.
Yeah, they just stick.
Mine's just like my style is an adhesive, so you just kind of peel the back off it,
Mhm.
slap it on, keep the hand on it for a few seconds, let it get nice and warm. Everything else, just carry on with my day. Transfers. I've never had one
So
come off.
are
And I have to get
colostomies
myself into some pretty funky positions.
are colostomies more common with quads as compared to paras?
I don't
Don't
know
know.
that answer for sure. I think it's now that we're seeing more with quality of life, I think a lot of quads they like it. It helps with the caregivers, especially a full quad who has not even any upper motor. That for their caregivers, they don't have to turn them over as much. They don't have to get them out of their wheelchairs just to clean up their bottoms. But I think it's such a personal decision. It kind of depends, but if you know someone that has an appliance, get one and stick it on your stomach for like a day and see what it's like, and then you kind
That's
of,
what
you know
I
what I
did.
mean? Like
I bought a bag from a friend that I knew had one, and I put it on, and I wore it down, and I played with it a little bit, shifted it underneath the waistband, and I had it all kind of figured out. Then went in and when I got it drawn, but yeah, I wore one around for a day, carried it around, just
You can put
see
some
what it was like.
chocolate bits in it, for fun, just to see.
Used
Oh, Henry
oatmeal.
bar.
You can hide your candy bars
Yeah,
in it.
So,
I used
Um,
oatmeal.
but technically, you can keep on doing digital decompaction until you're 90 years old. Is that correct?
Yep, absolutely, absolutely. Yeah, like if digital stim works for you and you're in and out in 10-20 minutes, but there's people that I hear the stories. I am a walking person, so I don't have the issues, but you hear the stories.
I'm an
And
hour every other night, but I don't mind reading while I'm on the toilet. So
what it is good, Paul, is just to know your options. If something stops working for you, then it's not, you're like, oh, I hear this option all the time, and I know a few guys or gals that have it, and I'll ask them again what it's like. But yeah.
Yeah, I can tell you that I wish I would have known a few years ago, like a lot of years ago.
It is the one phrase I hear. Why didn't I do this before?
Yeah, I agree with Duncan. I wish I'd have done this right from the start.
I mean, I do know a few patients that have gotten one. They did have a bit of a complication. It kind of comes out of the body, and they just need a simple surgery to fix it. So, I'm saying it's not a surgery that it doesn't have a complication, but the complications are fixable. And
okay,
again,
so what's the worst case scenario?
The worst case scenario is that the stoma retracts quite deeply under below skin line. And then you're wearing sort of what we call a deep convex. So you kind of have to wear a different thing and maybe a belt to hold that more in place. So that's, I'd almost prefer if you have the one that kind of comes out of the body more, that sometimes we just got to put a bit of sugar on. But it's when it recedes, but that only typically happens in those that are more overweight and have larger bellies, because where your intestine is deeper in your body, pulling it out to your skin. So if you're on the slimmer side, that risk is definitely decreased for you.
And it's reversible, is it not?
It's reversible. Yeah.
Yeah.
Something goes bad, you hate it, they reconnect your pipes and off you go.
And I got another hand up that we haven't heard from is Leslie Buck.
Leslie, yep.
Yes, hi. I was just wondering if we were seriously considering this for quality of life, would it be best to go to your physiatrist to get things started, or do you go through your GP, or do I ask to see you?
If you have a physiatrist, I think they work harder for you than your GP does. So that's where I would secretly suggest to start with. And they know, if you live in the Vancouver area, they know a lot of the Vancouver surgeons that they can do the request. If your GP is also good and is a good advocate for you, then you can go with your GP as well. So it's almost figuring out which one is better, your better advocate for you. Does that make sense?
Okay, I've already got a good idea on that one.
Okay.
I would ask too to make sure that they connect you with a wound care nurse, not a wound care, an ostomy nurse.
Yeah.
Because you need the input in terms of the appliances and where the stoma is and those kind of things. And I don't know, Erin, are you automatically called upon to do a placing of a stoma when the surgery is scheduled?
So yeah, so I'm actually acute care.
Yeah.
So we see the OR slate. We see who's getting an ostomy, whether it's urine ostomy or fecal ostomy.
Yeah.
And we call you, we talk to you about your upcoming surgery. And on day of surgery, we mark you at the hospital.
That's what I was wondering.
Yeah, so it's very quick. But if you want a bit more, if you know you're going to get one, and you look around your community, or you can ask some of us, where can I go to just chat with someone for like half an hour and not be in such a rush? And places like McDonald's and Nightingale, they'll see you before your surgery. They'll show you, they have more time than to, you've made an appointment to show you supplies and what they look like. And, you kind of hope if you're going to them that you'll kind of see them after and also get their supplies. That makes it more, there's always a business attached to it. So if you kind of like, hey, they're in my neighborhood, I'll probably see them after if I get one. They'd be happy to see you prior, and you can play, touch, and look at ostomy supplies in a bit more laid back setting. If that makes sense.
We got another hand. Susan, you have your hand up again?
Yes, I think you answered the question though. I was going to ask about the anus and that section of large intestine from the colostomy down to the anus. Do you have to worry about anything discharging from your anus once you've got a colostomy? Like you have mucus and stuff in there. Like, is there ever an issue with your needing to wear a depend or something just so you don't soil down there?
Yeah. Very, very good question. So in the initial couple of months after surgery, you may still get a small blob of stool, because there's still, stool stays in our intestines a lot longer than we think it does. It gets stuck in sort of our little alveoli or whatever. So you can, for a couple of months, get a little spot. It's not like a massive bowel movement. And as that clears out, it'll get less and less, and you won't see it again. You will get little blobs of mucus once in a while, but again, they're so small that it's, you'll just notice it in your underwear and you'll be like, oh, okay, I know what that is. But it's not like a gigantic, large stool or a large, like that you have a wet spot or anything that you would notice. It would just be a small wet spot in your underwear, and you'd be like, oh, okay, oh, that's just a little bit of mucus coming out. And again, it doesn't happen very often. It'll just be a little plop now and again.
Hey, Teresa, you got your hand up again?
Yes. So I'm just curious here. Do infections like bladder infections, urine infections, UTIs, do they decrease when you're on these ostomies?
If you got a fecal diversion, it doesn't change anything. Not unless you're getting UTIs because you're getting stool kind of up near your vagina, urethra area, and that's where you're getting your infection from. But your UTIs are just typically from catheterizations and having a catheter indwelling. It increases your risk. The only time it decreases a UTI is if, you've had bladder cancer and we're taking your bladder out and changing it to what we call a urostomy, which is a urine ostomy. But that's totally two different things. But that is a good question, though. Who has her hand up?
Oh, okay.
Did I hear you say that when the bag is full, you throw it out rather than empty it and clean it?
You can do either. Oh, sorry.
Yeah, so it'll depend on what you like. You can wear the same bag technically for a week if you wanted to. You just some of them will have a spout at the end or that you open. You'll sort of milk the stool out, clean the end a little bit and roll it back up. There are bags that you can click on when it's full and totally just discard and put a new bag on. I've kind of learned that each person has a strange relationship with their poo. Some people are like, I am not looking at this, and some people don't care. So it's all your relationship with your own stool. If you're happy to like milk it out and into the toilet, or you're like, I don't want to look at it, I just want to take a bag off, throw it away. So it'll all depend on your relationship with your own poo.
Okay, thanks. So
Okay.
my second question is, I've had Mitrophanoff surgery. Are the two surgeries compatible?
Ooh,
That's
I
a
will
good
have
one.
to get back on you on that. Being in working in an adult hospital, Mitrophanoffs are very, very rare for us. We're actually just got a new urologist who's going to make them for adults, so we're learning. I'm not sure. Can I get back to you on that and let Duncan know? Right
Okay.
off, my gut
Yep.
instinct is no, because you're still stooling through your anus now, so there's no disruption of stool. And where's your Mitrophanoff, on your right side or central?
In my navel.
It's navel.
Central.
Should not interfere because a colostomy would go on your left side. So my gut instinct is no, but I'd rather ask a few people if that's all right, Lynn.
Sure, thanks.
And Erin, there's one more slide in your PowerPoint that
Let's see what it was.
we didn't get to.
Okay. It was just sort of about, if you got one, what it
Okay.
looks like post-hospital. So in the hospital, people like me, because I'm acute care, we will see you right the day after your surgery, unless it's on a Friday, then we see you on a Monday. And we start the teaching with you right away. So we'll teach you a few times. We'll set you up with an ostomy nurse in the community at places like McDonald or Mackenzie or Nightingale, sorry, or there's actually a great one in New West that is open 5 or 6 days a week, so that you have a community ostomy nurse basically to help you for the rest of your life, and you'll get your supplies from the same place.
You also had a slide on, I
Oh.
know there was a big question when we were chatting about endoscopies, and we forgot to address that, but you did.
Okay. Endoscopies. What is it? Well, it's obviously if your doctor's looking for any risk of polyps in your bowels or cancer or something, it's that scope that they, put you under sedation and look up through your anus, and they go up through your large intestine, sometimes into your small. Obviously, they're just looking for pre-signs of cancer or ulcers, so that they can deal with them. The prep for this is so long because they really need to get all your stool out. Stool gets trapped in our intestines in these little sort of wavy things, and so they really need to clear all that out so they can actually see properly anything small. So it's a couple of days of some bad diarrhea. What to look for if you think you're at risk for anything, obviously it's blood in the stool, are signs, some cramping, or any dramatic changes in your bowel movements. Like sometimes we eat something bad, it gives us diarrhea for a day or two, but it's like something severely dramatic, is not your norm. And that's where you definitely want to ask your physician. That's sort of a bit above my pay grade, but that's sort of what I can tell you on the general floor level.
Wait a minute, Megan has a question.
Yep.
I just wondered if you'd had any experience with adults with cecostomy tubes.
Sorry, nephrostomy?
Cecostomy.
Oh, cecostomies.
Yeah.
We've had a few come through the hospital, but they kind of already know what to do. So we haven't had to do much except for just check in on them. But the idea is that you have this little valve, correct? And then you flush through sort of where your cecum was, and you can flush to kind of help with bowel movements. From what I understand, when you have a cecostomy, it's because your bowels don't have the natural peristalsis. So that is actually kind of, it's like an internal enema through your colostomy, correct?
Yeah.
Yeah. So we don't do them very often because if you have the natural waving of your large bowel, that moves stool along. But for the colostomy, it's when I think you've got like a sort of some nerve damage along that, and you kind of have to almost, in essence, flush so that the stool goes around and out. So
Yeah.
not a lot. Yeah.
Okay.
Yeah.
Thank you.
You're
Okay,
welcome.
and now all of a sudden we got a bunch of hands up. So Peter, I'll let you go because you haven't talked yet.
That's okay.
I just had a question about the exercise piece, Erin. For somebody like myself, I'm a C7 quad. I do ride my bike a lot and I go out and wheel in my wheelchair. Does that have any effect on like, motility with the colon? I know it would be better if, I was walking, but obviously I'm not going to be doing that. So do you know if there's any evidence that that helps?
I know it, I don't have any like evidence where I can quote it, but any form of exercise helps because your blood is moving, your body's moving, you're staying slimmer, and all that again works together. Because if you're have a bit of good heart health because you're exercising, that will in turn affect a lot of your body's organs, and they all fit together. So yes, whether I don't have anything in front of me to say, but we know that staying exercise, having your heart and blood move around a bit more vigorously, staying slimmer, all that, and kind of helps the mental health a bit too, does impact improve in keeping your bowels in a better place.
Okay,
Great.
good, Peter.
Thank you.
Paul?
Thanks. Yeah, sorry about asking so many
It's
questions,
all
but I just have a question about the frequency to stay with digital decompaction. I've done sometimes 2 days, sometimes 3 days, and I don't know if it makes any difference. And do you have any advice on that? I mean, I always think the more often that I irritate it, the worse it is. So 3 days is probably better, but I tend to do 2 days, and I rarely would do 1 day.
When you do 2 days, are you uncomfortable at any time?
No.
Then it works for you. Some people are fine at 3. Some people know that they need to do it every day. They just eat that much food and make that much stool that they need it out and can feel, you kind of feel your stomach get a little bit tighter, kind of blows up, like you're getting a little bit pregnant. But if you don't feel uncomfortable, your stomach doesn't feel tight, then that's fine.
Yeah, one of the things that happens with me is I'm on a medication to try and expand the bladder so it doesn't spasm so much. It's called Mirbitrique, and I believe that maybe slows down the peristalsis.
Yeah.
And I wonder if you have any experience with that too.
I don't. Apologies. I don't know the medications that well because I don't really work with the medications.
Mhm.
Yeah.
Okay.
Apologies for that. I don't.
Last question is about
Yeah.
the cost of colostomies. I mean,
Oh,
I've never had to do catheterization for urination. I've always just used a condom, and it seems to work fine. And that's quite cheap to operate a condom all year long. $300 3 times a year. But catheters, it's 10 grand. I have no insurance. And what are colostomies then?
So colostomies are covered under Fair Pharmacare like your medications are. So
Is that only if you're under a certain income level or something?
yeah, whatever, like
Not that I have any income right now, but
if you have Fair Pharmacare, so like say you when you go and get your drugs and you only have to pay 80% until you hit your thing, and then it's 100% covered.
no,
It's
I
like
pay
that,
everything.
okay.
I pay everything.
Oh, okay. We can always check for you if you're ever interested. It's just an online thing that someone can look for you to see if you're covered. You can go into an ostomy store, but we don't find many people have to pay full cost for their ostomy materials because most of us are covered under Fair Pharmacare, or we have extended health where we can can cover the rest. So it's a very small population of people that have to cover it 100%. If you're covering it 100%, yes, it's about $250 to $350 a month. So people like me and above me have worked hard to, lobby the government to make sure that it's sort of a covered thing. And the next we're working on is catheters. So hopefully everything's so slow, but hopefully the next 5 years catheters will be covered, like
There you go.
ostomy materials are covered. So
Pay to fee, pay to
yeah.
fee.
Yeah.
Duncan,
what do you notice?
Sorry, go ahead.
What do you notice with paying?
Yes, you have everything on file.
I started looking at Fair Pharmacare a year or two ago, but I have Blue Cross, so I didn't have to get into it too hard.
Right.
I think there is a financial assessment,
Yep.
but I know lots of folks that are on it that probably have more income than I do. So I'm probably going to have to investigate it in a while because I'm on Blue Cross because of my wife. And when she retires, I'm not sure what happens with our healthcare. But Fair Pharmacare does cover 100%. I know that.
Okay. All right.
Any more questions? The last time I asked this, we got like 5.
That's okay. I'm in no
Oh,
hurry.
Megan's got her hand up.
Sorry for the questions. Do you have knowledge about Peristeen? Do you work with Peristeen, or is that not a part of your caseload?
Oh, I think I know what this. We don't do it. I've heard about it. Isn't it like $500 or something?
Oh, it's way more than $500.
Or is it 2,000? It's ridiculous.
It's probably more like 9,000 or 10,000 for the year.
Okay, yeah, that's why I don't work with it. I've heard about it, and we, I just look at them like this was something I'll never do in my lifetime, so I don't want to put that information in my head because there's already too much. But yeah, I've heard of it, and yeah.
It's just really hard to find anybody who knows about it or supports it or can, walk you through it. That GF Strong, Ashley was doing it, but she's left now. So
I don't know when she's coming back. We still hope she's coming back.
I understand she's left, that she's got another job.
Oh, that has not been told to me yet. Okay.
Oh,
that's okay. That's okay.
I haven't heard that either.
There's one person, Lauren Wolf at McDonald's on Broadway. She sometimes knows these really weird things. So, I mean, feel free to give her a call or ask, call the pharmacy and ask for her work email there and see if she does. Because I know she'll always know that she works actually at VGH with me. But she knows these sort of really odd things because she's been in the business a lot longer than I have with ostomies.
Okay, great. Thank you.
Both with an E.
Okay.
Yeah.
Oh, one more question, Marnie.
Well, a bit of an answer. I think maybe for the Peristeen. From what I understand, it's like very not labor intensive, but it takes a long time. Like it could take like 2 or 3, 4 hours, and it's a clean routine. That's just what some people really need.
I use it. I know it. It takes 3 or 4 hours. You're absolutely right. Which is why I'm asking all the other questions. It's terrible, horrible. It's a horrible system.
Oh, okay, good to know. Okay, it's nice to hear people who've used it because sometimes we get reps that try and sell us on stuff, and we're like, we're acute care. I'm sorry, like I don't work in the.
It saved my life, but on the other hand, it's horrible.
Okay.
So worst part of my week.
Oh, I'm sorry. Oh.
Yeah. I want to thank Erin for actually doing the presentation. It's, she's done it just out of her goodwill, and I don't know if she knew how much she knows.
Well,
she's got all the knowledge that we needed. I hope you all appreciated it. We're going to take a little break from ed sessions for the summer, and I've booked another 3 for in the fall. But I want to thank Erin for doing this and let everybody go. Thank you very much. It was great to have all the questions. I hope we answered everything you needed to know. Okay.
Thank you.
All right.